our next lecture is going to be on part 2 of macrocytic anemia. This is folate deficiency. We've talked about vitamin B12 causing macrocytic anemia. The second vitamin responsible for this disease is folate deficiency. Well, let's talk about it. Folate is usually stored inside the liver also, but the problem is the stores are very, very limited. We can only store folate for only 3 months. Only. That's why it's easy to develop folic acid deficiency easily compared to vitamin B12, which is stored for 3 years. Wow, I would take B12 over folate any day. Exactly. Now, where do we find folate? You betcha there's a reason why I drew this little green vegetable on the board. They are found in green vegetables. Like, look at the word foliage. Foliage means leaf. Therefore, folate comes from the word foliage, which is found in green vegetables. So, unfortunately, some people cook their vegetables so much. If you cook your green vegetables so much, you're going to lose all the folate that's in it, and you're just eating a piece of paper. So don't overcook your vegetables. That's a cooking advice in our lecture. Now, what causes folate deficiency? That was great. The first and the most important, because we only store it for 3 months, that's it. It's very easy not to have enough. So causes will be dietary, right? Insufficient dietary intake. Insufficient dietary intake. Usually, who are the people that don't eat enough? They're usually old people. They eat there's something we call tea and toast diet. That's all they eat all day, tea and toast, tea and toast. The problem is they're going to run out of the folate that's left up in their body, and they're going to develop folate deficiencies. The 78-year-old grandma that just eat every day a little teacup and toast diet. That is by far the most common cause of folate deficiency. The next one are my friends. Guess what? Alcoholics. People that drink alcohol do not eat food. I'm not talking about people that socially drink on weekends. No. I'm talking about the alcoholic that wake up brand new in the morning, right early in the morning, and the first glass they grab is not a glass of water to wash their teeth. It's a bottle of vodka or Hennessy. Yeah, that's what I'm talking about. Those are the alcoholics, right? They drink all day. They can drink straight. And these people can go without days without eating. Let me tell you why. Because alcohol actually has calories. There's actually 7 kilocalories per mole of energy inside alcohol, and it's been metabolized in the body, so they don't feel hungry. They get a little bit of energy, but it's enough, so they have very poor diet. So because they're not eating, they develop folate deficiency. Also, if you're using long-term use of antibiotic, if you're using antibiotics for so long, this can kill the bacteria inside the gut and also prevent you from being able to reabsorb folate inside the body. Also, during pregnancy, folate is extremely important. There's a high demand for folate during pregnancy. Why? Because folate is responsible for DNA synthesis. Exactly. So if there's DNA, we got to make a brand new cell. So if a woman is pregnant, you want to tell the patient, once they find out they're pregnant, they have to take folate. Because if they don't take folic acid, their baby is at risk of developing neurologic problems, right? Because folate is required for cell turnovers and cell synthesis. These patients can have severe neurologic complications inside the womb. Also, hemolysis. Lysis of red blood cells. And if you're using folate antagonists, like drugs that prevent folate from being metabolized, what drugs are we talking about? Methotrexate. Methotrexate is one of them. Those drugs prevent folate being metabolized in the body. They inhibit dihydrofolate reductase from being able to function, and then we cannot have enough folate in the body. And also, if you take anticonvulsants like phenytoin, or you're on hemodialysis, those are the things that can cause you to develop folate deficiency. Now, what are the clinical features of folic acid deficiency? I've got some news for you. It's exactly the same like B12. Just exactly like B12 deficiency. Let's review that. Clinical features. They develop megaloblastic anemia. The MCV is greater than 100. Okay, and they have macrocytic red blood cells, which are very big red blood cells. Now let's visit the chemical reaction where folate causes megaloblastic anemia again. We said methyl tetrahydrofolate is often converted into tetrahydrofolate, and tetrahydrofolate is converted to 5,10 methylene tetrahydrofolate, which now converts D-dump, that's how I remember it, dump, to be into DTMP, which forms thymine, which is incorporated into DNA. Well, this tetrahydrofolate is actually converted into dihydrofolate, which is now eventually converted by dihydrofolate reductase enzyme, which catalyzes this reaction to be able to recycle and make more tetrahydrofolate. Now, if I have folic acid deficiency, what happens? Well, I can't catalyze this chemical reaction, right? Because I can't go this way. Now, I can go down this pathway. I can make thymine, and I cannot make DNA synthesis. Well, in a cell like the red blood cell line, where DNA needs to be made, right? We need to make DNA to make a new cell. Well, cells are going to be stuck in the G2 phase, in the growth phase, because they cannot grow. So they get really, really big and become macrocytic red blood cells, and that's why folate causes megaloblastic anemia. But folate does not cause neurologic symptoms. That is what makes it different from vitamin B12. B12 causes neurologic symptoms, but folate does not. Also, these patients can have a sore tongue known as stomatitis or glossitis. Stomatitis or glossitis. This is also present in vitamin B12 deficiency. And so that's basically what the signs and symptoms of folate deficiencies are. Now, how do we treat this? Well, treatment is pretty easy. They don't have folate, basically give them oral folic acid supplement. Tell them to take folic acid and they will just be fine, and you fix their anemia and the patient feels much better. Also, you need to check for serum homocysteine level, and because in patients that have folic acid deficiency, they develop elevated homocysteine, high homocysteine level. And let's see why. The reason is because vitamin B12 catalyzes this reaction by taking this methyl group and becoming methyl vitamin B12, and that actually converts homocysteine into methionine. Now the problem is if I don't have folate, right? If there's no folate, B12 cannot work. If B12 cannot work, it cannot give the methyl group to homocysteine to make it into methionine, and thus I'm going to have high levels of homocysteine when a patient has folate deficiency. But the difference between B12 and folate is because In B12 deficiency, patient has high levels of methylmalonic acid, and that is what distinguishes it compared to just folate deficiency. All right, and that brings us to the end of macrocytic anemia. It's Adeleke from Future Teaching Physicians. Till I see you again, have a great day. Bye-bye.